Okay, good afternoon, everybody. I'm going to try to stay on time. I'm a bit of a fast talker. Sorry, I'm going to keep that up. Thank you to the inviters, to the organizers for inviting us here today. It is a tremendous honor to be here to report on the first 2 years of experience in Canada with medical assistance in dying. It is always a daunting task to speak after Shanaz, who is so eloquent and so passionate about what she speaks about. But I'm hoping to attract your attention by launching into some of the data and the details of what we've been doing in Canada. And I'm going to also highlight, as Derek mentions, the role of the Canadian Association of MAID Assessors and Providers in that evolution, as I think it's key. I'm not going to waste very many minutes on myself, except to put you in context. I am actually trained as a family physician. I spent most of my career in newborn and maternity care, but I switched in 2016 when our law changed, and now 80 to 90% of my practice is in assisted dying. We've been very busy in British Columbia. At this point, I've done over 250 consultations for assisted dying, and I've assisted more than 100 people to end their life. There we go. I think this is a room I don't need to spend too much time on terminology. I think we're all aware that assisted suicide is when a clinician prescribes or offers a medication that the patient takes themselves, which causes their death. And voluntary euthanasia, of course, is when the clinician themselves administers the medication that causes the death. What's interesting is that in Canada, very unlike other jurisdictions, we actually have the option of both, and both of them are in our law. And that terminology we use, medical assistance in dying, is the umbrella term that includes both of those options as long as they're administered by either a physician or a nurse practitioner. And I'm not going to keep saying medical assistance in dying because it takes too much time, so I will refer to that as MAID from now on. Okay, having these options available to us, of course, puts us in this very exclusive club. As far as I know, there's only 3 other jurisdictions in the world that have both of these options available by law. And I don't need to name them, you all know who they are. So what do we know from others? That would take an entire weekend to go through, but we did look at our colleagues in the Netherlands to consider what way, and just very briefly, just the very basics. The vast majority of the cases of euthanasia in the Netherlands are done by the GP, by the general practitioner. That's actually not necessarily bearing out to be true in Canada. The underlying illness in the majority of cases in the Netherlands is cancer, which was not a surprise to us. And just looking at the very basic data, if you look at 2017, we'll see that of all the annual deaths in the Netherlands, euthanasia accounts for about 4.4% of them. So we thought, well, maybe this is what's going to happen in Canada. We'll see. So I'm going to talk to you today about what is going on. First of all, you need to know where to find us on a map. I'd like to think that everybody in the room can, but I'm a little Canada-centric, so in case you weren't sure, we're that really large green country there above our little bit louder counterparts below. These days, we're rather proud to be distinct from our southern cousins. Always have been, just a little more these days. We're that very, very big green country. And I wanted to give a sense of the size of our country. I've superimposed a map of South Africa on top of Canada. So you can actually fit South Africa into Canada 5.5 times by area. So we're really, really large geographically, but we're not that many people. I am going to actually take a real minute or two to just talk a little bit about Canada here, because I think that before I share our data, it's going to provide some context for our country, how we're made up and how things are run and administered. I think it may inform some of the trends that I'm going to talk about. So I do want you to understand a little bit about this big, big country. We are, in fact, very large geographically, but we are only 36 million people. We are divided into 10 provinces and 3 territories that are in the northern part. I don't have a pointer, but the northern part there. We have a federal law. Our law covers the entire country. It's not a state by state or province by province, so that's wonderful. But healthcare in Canada is administered provincially. And provinces have the ability to decide how to do that. And because there are 10 distinct provinces, they're distinct by population, by culture, by a number of different factors. And so how each province has decided to administer this law and health in general is quite distinct from each other. I'll just give you a few examples. I actually grew up on the east coast in Nova Scotia, way on the side there, little kind of reddish purple. It's very small. There's about 750,000 people that live in Nova Scotia. But right next to us, there's a province that you can't even see on the map. It's so small. It's a little island called Prince Edward Island. And Prince Edward Island has 150,000 people on the whole island. And to date, in the first 18 months, they've had 10 cases of assisted death. So that's the smaller end of things. Right next to it is Quebec, which many of you may have heard of. Quebec is a very large province in Canada. It's about 8-point-something million people. And Quebec decided, hey, we have the ability to administer health provincially. They didn't even wait for the Canadian law to change. They went ahead before us, as many of you know, and changed the law provincially to allow assisted dying. And their law came into effect in December of 2015. So it predated the national law. So very distinct. If you go a little bit towards the middle, you'll see Manitoba. Actually, in Manitoba, a family doctor cannot provide an assisted death to their own patient. All assisted death in Manitoba must be done through a one-MAID team. There's only one MAID team. Now there's two because there's so many requests. But 60% of the population in Manitoba lives in one city. And so they thought they could get away with that. And there's no movement to change that structure in Manitoba. I live in British Columbia now, way on the other coast. I seem to like the water. I'm going to point out to you a little bit later on, you see there's a large island at the bottom there which says Victoria on the tip, which is where I live. And I'm going to talk a little bit more about that area later, so just to point it out. But in British Columbia, if I help someone to die, on the medical certificate of death, I must, by provincial ruling, write medical assistance in dying as the #1 cause of death, and #2 has to be listed the underlying illness. If I live in Saskatchewan in the middle of the country, I'm not allowed to write that. I actually have to, by provincial law, write suicide as the reason. You can imagine that doesn't go down so well with so many people for so many reasons. In Ontario, you're not allowed to write either. In fact, you have to write only the underlying illness on the medical certificate of death. So you can see we have one federal law, but we've got lots of different ways of implementing it. And so it makes a difference. And my point is that when we're looking at the data and talking about provinces, we're not always comparing apples to apples. So I just want to make that clear before we start. All right, what is going on? Well, to date, by December 31st, 2017, it had been 18 months since our law had passed. All the data I'm going to present to you is from the 18-month data. Officially speaking, if you ask Health Canada, there have been 3,714 assisted deaths in Canada. This does not include any data from the Northern Territories because they've decided the numbers are too small, they don't want to include them, but actually it is going on there. And this number also includes all of Quebec's data, including the 6 months prior to the Canadian law. So, how accurate is this number? We'll see. But that is the official number of how many deaths there have been. What I can tell you, if you look at the data, if you look at every single region in Canada, every single province, there has been a trend every 6 months of an increasing amount of total deaths, total assisted deaths in all regions of the country. It's pretty bar. And Quebec has an extra blue bar that represents their first 6 months, which is different than everybody else. So it's a definite trend. If you look at total assisted deaths across the country by just raw number, you can see there's a couple provinces that stand out. Ontario and Quebec are our two most populous provinces, and of course, by raw number, they definitely have the most assisted deaths. You can see British Columbia is coming up a third there, a little bit surprising because we're not as populous. But I thought this graph in blue didn't really represent a good way of comparing jurisdictions because the populations are so different. So I converted that data to a percentage. So looking at provincial annual deaths, how many of them were caused by an assisted death, and that's what the green bars are at the bottom. You can see a lot more evenness across the country. When we look at those numbers just alone, just looking at percentage of total deaths that are by assisted death, I confused you by going back to blue. But you can see there's a little bit more variety. But again, British Columbia seems to be standing out here. And so I, of course, find that personally interesting. In terms of Canada overall averages, basically, at the end of 18 months of doing this work, 1% of all total deaths in Canada are by assisted death at 18 months. So after the first 6 months, it was 0.6%. After the first year, it was 0.9%. And at 18 months, it's 1.07. So that's where that's at. I wanted to compare it to other jurisdictions in the world. The first bunch of bars are all from Canada, of course. We can see Canada there, and we wanted to compare it. So compared to Oregon, we're doing much, much more. Not surprisingly, we're doing less than the Netherlands or Belgium, who've been at this for quite a bit longer. And depending which year's data you look at, their percentages change up and down. But I wanted to just highlight the last 3 bars. Those 3 bars represent that little island where I live on Vancouver Island, just the Vancouver Island there, and a couple little islands in there. And in the first 6 months that our law had changed, by the end of the first 6 months, 2% of all deaths on the island were by assisted death. And after a year, it was 3.6%. And after 18 months, it was 4.4%, which is on par with the Netherlands and Belgium, which is a huge uptake and much, much quicker than we expected. I can tell you, if you just look at the last 3 or 4 months alone, away from the other data, we're over 5%. So something quite unique is happening in that area of our country. I'd like to spend more time on that, but Derek's going to yell at me. So if you want to talk more about that later, we'll do that. I want to get back to the Canadian data in general. If we look at across the country, this is now national data based on whatever Health Canada says is the official numbers. I should note that we don't actually have official reporting yet, so take it all with a grain of salt. Gender-wise, it's pretty much even all across the country, male-female, no surprise there. There's really no standouts. Age-wise, this is an old scatter graph. The spectrum is a little bit wider, but across the country, the average age of anybody accessing assisted death in Canada is 73 years. It's between 72 and 75 in every province. The youngest person I've helped is 27. The oldest person I've helped is 105, so there's a huge, huge range. In terms of underlying diagnosis, it's not surprising that the most common underlying diagnosis is cancer. It's what we expected, and it's what we're seeing in every province. Second most common underlying illness is actually not neurologic, which we thought it might be, but it's end organ failure. So end-stage heart failure, end-stage respiratory disease, end-stage liver failure, that kind of diagnosis, what we're seeing, and then followed by neurologic disorders. In terms of where this is happening, the answer is everywhere, but predominantly in most places in the country, it's happening in hospital. This graph is a little bit deceiving. It looks like home, community, and hospital are relatively close, but this is because in British Columbia, over 50% of the cases are happening in the home, in the community, and our numbers are so much higher, they're dragging the national data up. In most cities in Canada, getting an assisted death in the community is not that easy, and a number of hospital systems have stepped in to build infrastructure to allow this to happen, but they're in larger centers, so it's not always happening in the community. It is happening in residential care homes and palliative care homes and hospices everywhere in British Columbia and in other places as well. Urban versus rural, I'm not going to spend a lot of time. Obviously, originally much more common in large urban centers compared to rural. That's slightly changing over time, but not grossly. I think what I really want to point out is this data is interesting and helps us inform what's going on, but what's really happening is that we're missing certain data. I think it's been 2 years. We've been doing this over 2 years. We actually do not yet have national reporting. That's due to come into place November 1st of this year. There will be then some more robust, more consistent data from across the country that we can use, and that'll be helpful. But what I find interesting is what's not being collected now and what's not even slated to be collected, and that is what happens to the people who've made a request for assisted dying, but actually it didn't happen. So did they change their mind? Did they die while they were waiting? Did they lose capacity before they were able to go through with this? That data is not being collected, and I think that data is probably as important as this data. And I think that as well as we're doing in Canada, and I'm immensely proud of what we've achieved, I think we could do a lot better. Now, Derek, don't cut me off. I'm leaving myself 4 or 5 minutes to talk about what's near and dear to my heart. So I'm going to just highlight very briefly the Canadian Association of MAID Assessors and Providers. And this has been a valuable tool for us in Canada, really a tool to support the people that do this work. And this tool has been important because if the people, as Shanaz mentioned, if the people who are going to step forward to do this work don't feel supported, then you won't have more people stepping forward to do the work. And no matter what the law says, if you have access, it's meaningless if there's no one to fill the job. And I think we're seeing that in the United States, in certain places like in Washington, D.C., and even other states. There's just, you can't find a provider. So this story actually, well, this is a nice slide from the island where I work, just shows that the number of people, the number of clinicians willing to be involved in assisted dying in some way to assess patients has gone up over the 2 years, nicely, that nice red line, but the number of people willing to provide has stayed relatively stagnant. And of those 24 people or 20-something people who are allowed on our island to do this work, who've been privileged to do this work, about 70% of the work has been done by less than 6 people. So it's still an issue. Getting providers to do the work is a significant issue. But this real story begins with the World Federation of Right to Die Societies. The outstanding conference that was run 2 years ago in Amsterdam was truly inspirational to many of us who've begun this work. And a few of us from British Columbia went over there expecting to meet other Canadians and kind of get together and meet and start networking. And there were no other Canadians there. But the conference was so great and so robust and so much was going on, we couldn't get to everything we wanted to do. So we literally literally broke apart. We each went to different lectures and got back together at the end of the day and shared notes and set up a little email group, and it was tremendously helpful to each other. And when we went back to Canada and started working, we already had this very small little group of 8 people that could support ourselves. And this was all brand new, so very practical. The first time when I went out to help someone, I talked with my colleagues. This is what happened. This is what it felt like. We talked about how do you deal with the funeral home, and they didn't expect to know which time to show up. Who pays for the tubing? Like, all the practical details became really important to share with each other, let alone the emotional debriefing that we all had with each other. And it occurred to us that we weren't the only 4 people on the planet doing this work, and there were probably other physicians somewhere in Canada working in isolation that could benefit from joining our email group. And so we reached out through our friends and through our resources and through Dining with Dignity and tried to quickly connect with those people across the country, which we were able to do. And we quickly launched a national listserv, an email listserv basically, that connected these people. And at the end of the year, we had 100 people, 100 providers from across the country connected through this. And some people were very much on their own, and others had communities around them. After that, we realized quickly by talking to our colleagues across the country, there was more to be done than just connecting by email. There were issues that were happening, obstacles that were happening that shouldn't be happening, and there was inconsistency across the country. So we launched the idea of CAMAP, of the Canadian Association of MAID Assessors and Providers. And it has 3 main missions. Number 1 mission is to support the people that do the work in whatever form that takes. Number 2 is to educate the population, the public, and the healthcare community. They needed education about what MAID is, what it looks like, what the law says. So educating both public and the healthcare community. And really important to us is to help provide leadership and be a voice in leadership in setting medical standards for this care. There's no other group, there's no medical association out there that speaks for the people that do this work or sets this standard. And we hoped to be at conferences like this and speaking to other people, people would be looking to see what we're doing, and we wanted to do it well, and we wanted to do it right, and we wanted to do it robustly, and we wanted to set high standards medically. So to be clear, CAMAP is a medical association. We are not an advocacy group. We're a medical association, dedicated to these 3 missions. So with our listserv and our fervor, we developed a newsletter to connect not just the people that do the work, but we decided to open this organization up to anybody who's on the team of assisted dying. So the policymakers, the legal counselors, the social workers, the spiritual leaders, nurses, nurse practitioners, anyone and everyone. And we made this newsletter online and sent it out to as many people that would bother reading it. And we talked about what was going on across the country and where solutions have been found and where obstacles still remained. And through the newsletter and through the listserv, we were able to grow our membership in the first year to the point that we had a couple hundred people, and we decided to be very brave. And we actually had representation from every single province and every single territory by the end of the first year. And so we threw a conference. We said, let's have a conference. So the first year we had a national conference on MAID in Victoria that we hosted to celebrate the first year anniversary and to really bring the community together. And I'm very, very proud to say that conference, when I went to book the room, I didn't know how many people would be there because we were still, 6 months before the conference. I had to book the room. I thought we might be like 30 people because, everyone was scattered across the country and we were kind of far for most people to show up. So we had 130 people show up to the conference, and we had 14 different fields of, social work, nursing, medicine, law, whatever those are called, disciplines. We had 14 or 15 different disciplines in the room, and we were all in one room, and there was no breakout sessions, and for 2 days straight, you could feel the buzz in the room. Like, we had focused engagement. It was an amazing experience. And what we all realized is that there was an incredibly multidisciplinary team involved in this care. That's the way we wanted it, and we wanted to engage with each other. It was fantastic. We followed it up with a second conference last year in May. We doubled in size, 270 people. We had national partners on the podium with us, Canadian Medical Association, Canadian Malpractice Protective Association, Health Canada, all with us at this conference. Really tremendous. And I could spend even more time talking about everything that's CAMAP's doing. Very, very proud of what we're doing. Someone already mentioned Dr. Wiebe is running case-sharing seminars every 6 weeks online, invited assessors and providers from across the country to join in online during that hour and a half. We review usually 4 cases, talk with each other, what the issues are, how we might have solved them. Tremendous learning opportunity. We've been consulting with national agencies. We've actually established clinical guidelines for how to interpret our law so our clinicians know what to do when they try to interpret the law. We've established best protocols for oral medication. We're working on one for IV. There's a number number of guidance documents all in the works about to come out. So lots and lots going on. I think I just want to end by saying just a few things. It has been a remarkable 2 years in Canada. It's been incredible what we've been able to achieve in the last 2 years. So very proud of that. And the data that's coming in is beginning to inform us about what's going on and what it's looking like and who's being affected. But there's very important data that's missing, and we can definitely do better than what we're doing. I like to think the CAMAP has been truly an integral part of the evolution of MAID in Canada, and I highly recommend that any jurisdictions that's setting up do something similar in some way to support the people that do this work. I think it's made a huge difference in the unrolling of this. And there are still issues of access and process that remain. We're certainly not utopia. So I'm going to hand the podium over to my colleague, Dr. Dawes, who's going to dig down a little bit deeper into the nitty-gritty of some of the other issues, and then pass it on to Dr. Wiebe after that. Thank you for your attention.